found this patient as a child suffering from chronic ear infections. They've also had a grommet in this right ear, so this is the right ear. Ever since, they've always felt their hearing not to be as acute in their right ear as opposed to their left ear, which was clear. We took it at the beginning of the video. You would have seen the examination video of the left ear, which is absolutely fine and normal. A week ago, however, they started experiencing a throbbing sensation in their right ear. They visited their doctor locally, and who advised them that they got a wax impaction. As a result, the patient decided to travel up to Leicester, where my clinic is. So that's in the Midlands in the UK and England, to have it removed. Now, although this looks like wax, it's not. Initially, the patient, we both felt it could have been, on first appearances anyway, that it was wax, and the patient impacted it because it did admit to using a cotton bud. Just a solitary occasion, but sometimes that's enough. However, as soon as I made contact with this occlusion with the fine end suction probe, I realised immediately this is not earwax, it's dead skin, keratin. Now, I put drops in immediately because the patient was slightly anxious, slightly nervous. They've had a bit, obviously, with their childhood infections. They've had negative experiences with their ears. And the drops are just designed to help soften this dead skin. Now, why is this dead skin there, and what's it doing, and why isn't it coming out naturally? So this patient suffering from eustachian tube dysfunction. So behind the eardrum we have the middle ear. The middle ear should be air-filled, and the air pressure behind the eardrum should be equal to the air pressure in the atmosphere. And there's a tube called the eustachian tube that's positioned behind the eardrum that connects to the back of the nose, the nasopharynx, which is the air pressure equalizer in the ear. And the eustachian tube is generally closed, and during brief moments of yawning or swallowing or eating, the eustachian tube opens and it equalizes the air pressure behind the eardrum, so it's equivalent to the atmosphere. If that eustachian tube is blocked, or anatomically it's always shut, it doesn't open, and that could be because it's really, really narrow, or the muscles that contract to open the eustachian tube are very weak, there's a vacuum effect. There's no air in the middle ear, so the eardrum gets sucked in. And typically it gets sucked in the attic, so the top part of the eardrum. That's because the top part of the eardrum is known as the pars flaccida. It's a bit thinner and weaker compared to the pars tensa, which is the main body of the eardrum. And the eardrum and the ear canal is lined with a layer of epithelial skin cells. And this skin, as it dies and sheds, it should migrate out of the ear naturally, like a conveyor belt, and as it does, any wax that's sitting on the surface of the skin is also transported out of the ear. However, when your eardrum's sucked in, this skin that migrates off the eardrum, as I said, it typically travels down the ear canal. It gets trapped in the pocket, and it can't escape. Then we get more dead skin in that pocket, and that skin can collect, and in the worst case scenario, it can lead to a cholesteatoma. You can just see there, when I removed that last piece of keratin, it got stuck on the left-hand side. So this patient's got a really, really severe retraction on the back part of the eardrum, which is the left side, and also at the top, the attic, you'll see there's a little cave there, a little pocket. So they've got eustachian tube dysfunction. This skin got trapped in the attic, and in the posterior part of the eardrum, it couldn't escape, and it started to collect, and it gets hard and crusty, does this skin. You see by these still images, it's almost like shards of glass. Now, in the worst case scenario, fortunately, it doesn't appear that this patient has got a cholesteatoma, but this skin can get infected, and it can really grow, and it can grow into the middle ear, up towards the brain or facial nerve, and cause serious, serious damage. It can lead to meningitis, a brain abscess. In the worst case scenario, it can actually kill someone. So there's no visible evidence there of a cholesteatoma, but nonetheless, I've written to the patient's GP requesting that they refer onwards to ENT because there is quite a severe retraction, especially posteriorly, and there may be something surgically that can be done, i.e. grommets or eustachian tube balloon dilation. I'm just going to go through some of your questions now. One of the questions were relating to the size of the ear hook. They're wondering why it's a bit bigger than probably other channels that have used ear hooks. So the St. Bart's ear hook is probably the most universal ear hook used. They are standard sizes. The eye clear scope does provide great magnification, so sometimes it can be a bit of an optical illusion. However, there are some thinner types of hooks. They're called Cawthorne's hooks. They are typically made of stainless steel. They've got a really sharp edge to them. They come in different sizes now. In 7 years of performing earwax removal, I've never really had to. I probably have to use it twice in my whole career. And because I train other delegates, I obviously to use those instruments, which I'm more than comfortable using because I'm experienced now, but I wouldn't want new people who have just been trained using that. So we use the carbon fibre St. Bart's ear hook, and because I'm training other people, I want to be using the instruments that I'm going to be training other people with. I have occasionally used a Cawthorne hook, but they're a lot slimmer. I've never really felt the need to use it. That's why. There was another question about whether twins have the exact same anatomy. For example, same feet, nose, ear canal. I really don't know. It's beyond my remit. It's not my area of expertise, but maybe there's other twins out there who can answer that. I think someone did reply to that question and said, no, it's not always the case. There was another question about how to keep your ears cleaned. Don't do anything. That's the only advice I can give. Let the ears self-clean. If anything, you can use some olive oil spray, medical grade, for safe use for the ear. A couple of squirts in once a week maybe. Tilt the head to the side so it can seep into the ear, and after a few minutes, come back the other way, let it drain. Someone wanted to know whether a mastoidectomy can cause permanent hearing loss. It can cause sometimes some degree of hearing loss, but no, quite often people with mastoidectomies have normal hearing. Some have a slight hearing loss, like what we know as a conductive loss. There was another question about what is a cholesteatoma, so hopefully I've touched on that in today's video, but I've done many a video on cholesteatomas before, so on my channel, just type in cholesteatoma, you'll see loads of videos there make reference to that. Someone wanted to know whether I've ever used a microscope to look in the ear, I think specifically to differentiate between a fungal ear infection or cotton wool fibres. Answer is no. I've got actually 2 operating ENT microscopes in my clinic, but they are collecting dust. I really don't need to use them because of the endoscope. I think the view for me is far superior. Some people do use a microscope for one reason or the other, but myself personally, I'm very comfortable with the endoscope, and I don't really feel the need to deviate away from that. Someone else was being a bit cheeky and asked 3 questions. First one was whether after removal of cholesteatoma, that cause more of an issue with the skin migration. Yes, it can sometimes, because when you remove a cholesteatoma, sometimes it creates a mastoid cavity. Skin can't migrate naturally because of that, because it's a cave, it gets trapped. They also asked whether I get annoyed if anyone refers to me as a doctor. I do, purely because I'm not a doctor, and I don't want anyone to wrongly assume that I'm claiming that I'm a doctor, and that's the only reason. And they also wanted to know why audiologists, I think, not called doctors in the UK. It's because audiologists in the UK don't study medicine. It's like an optician. There's a separate degree, and it's the same for audiology. Someone else wanted to know whether they've got a damaged cochlea, whether there's anything that can be done with their hearing. Yes, potentially there could be a cochlear implant. You could have a cross-hearing system, CROS, and also you can have a bone-anchored hearing aid, also known as a BAHA, BAHA. So if you can just Google those, cochlear implant, a cross-hearing aid and a BAHA, they're potential things that can help. Someone asked whether the iClearscope is available in the US. Not currently. It's just this needs proper training. I could quite easily sell it. It'd be great for me. It's easy money in my pocket, just selling a device. But problem with that, as a responsible manufacturer of this device, it's probably not safe for someone who's not been trained to use this. And it's not all about the money. It's about making sure people are trained adequately. So currently no, but let's wait and see what happens in the year ahead. So I'm going to leave it there, guys. Quite a few questions yesterday.